Hello, guys. Hope you're all doing well. So, guys, haven't you had enough of me today? Like 6 hours. So, I have to say hello to my new friends who I see here. So, basically, this is a class that's in which we want to give you a taste of what's happening exactly in our ACJ classes. So I see familiar faces like Prakriti and Ismail and Purvisha, and hello to the others. So I'm going to wait for like 5 minutes and then we will start. Prakriti, aren't you tired already? Hearing 6 hours, just being in my class. So hello, hi. So if you one question left. Okay, what's the question? Okay. Okay. So if you would be able to send what you want to send to the group chat, that would be really great because I'm seeing your chats in my phone. Cannot open it here in my laptop. So again, hello to everyone. Hope you all are doing well. Okay, for you guys who don't know me, my name is Dr. Amin, and right now I'm instructor at U of D and practicing for the NDEC. So I really hope that we would be able to help you to pass the ACJ really easily. And most of almost, I think, 12, 13 session of the ACJ radiology is with me. I am a resto specialist back in Iran. And here, as I told you, I'm practicing for the NDEC and everything about it. So I talk about it sometimes in classes for the students, for my fellow friends here. So if you have any questions, you can go ahead and ask. If not, I'm gonna wait for like 2 minutes for everybody to join. Oh, Muna is here as well. Hi. I'm surprised. I thought that you're going to sleep. Okay. So basically, guys, how things are going on in our sessions, attrition, abrasion, erosion, are these anomalies? No, you cannot say they're anomalies, Prakriti. Those are the things that I just, put them in a single, category for you. When I want to, when I want to just organize my mind, I just put them in the orders. So that's why I put them in there, but they are not anomalies. No, of course not. So basically what we do is that um, we are giving the participants some quizzes and they go over them, and the day after that we are covering the answers. And normally me myself, I add some extra material, the things that I find them more important. And for example, today we were going through the how you can find out the age of the patients in the mixed dentition, for example. And normally when we want to cover the answers to the questions, I give the participant a poll and ask them to answer the questions in the poll. Then I will pick one and we will talk about it together. So please check this question and let me know what you think is the correct answer. the amount of time that you have in the real exam for each question is something about 1 minute and a half. Okay, so if you can manage to answer in that time, that's good. It means that you're good. So that's the amount of time that I'm going to give you. Okay, I think that's fine. Okay. So I'm going to start with my friend here, Vanshika. Vanshika, do you want to participate? Hi. You can unmute yourself if you want. Hi, how are you?
Hi there, doctor. I'm doing good. How are you?
Thank you so much. Did you take your AFK?
Yes, I did. I just did like on August 13th. This is one of my first classes I'm attending.
Okay.
This is
So,
late right now.
so are you familiar with the concept of the ICCMS?
I am, but
Okay,
I
perfect.
do need to revise, so I'm gonna be wrong there for sure.
Okay, no problem. So basically, RA1 to RC6, what do they mean? RA1 means the caries that we have in the half of the enamel. It's
Yeah,
not reaching half of the enamel.
yeah.
RA2 means it went through the
Through the
enamel,
enamel, yes.
and it might and in these caries we might have the DEJ, DEJ might be caries at the same time. So RA3 means that outer third of the dentin, RB4 middle third, and RC5 inner third. So here on the mesial of the 2-7, what is the category of the caries that you see here?
Um, I think I can see the dentine involved here.
Yes, this is dentin
Yeah,
is involved.
yeah. So it's not A or B
Okay,
for sure. It looks like the middle third of the dentine. So
middle third.
yeah,
So you are going with the RB4, I guess. That would be RB4.
right, right.
Okay. The thing which is really, really important here, Vanshika, is that when you want to assess, okay, we have a pulp chamber here like this, okay, and then we have enamel. So we shouldn't just consider the extent of the caries here, but we should see how big is the pulp chamber is, because this classification, dividing this in three is the distance between the enamel and the pulp. So when the pulp chamber is bigger, it means that we can easily get in the inner caries. Okay, so based on that here, both on the mesial and the distal, although these caries, this is bigger than this one, but
Right.
both of them are in RC5 stage. Okay, and that's meaning that they are in the inner third of the dentin. Okay, so and why is that? Because the pulp chamber is more mesially, okay, comparing to this is more mesially when you look at it at the. So now, what is the do you have my voice?
No, I did. I
So
didn't got you.
what is your treatment here, Vanshika?
Definitely restoration,
Yes. So what is that going to be? So it can be amalgam restoration or
or
composite
can
restoration.
composition.
Yeah, that is correct. So it can be amalgam or it can be composite. So do you know what is resin infiltration, and for which lesions we are using that?
We are using that for smooth surface caries on the mesial or distal aspect.
For which caries?
For smooth surface caries on the mesial or distal, like in between the two structures we use.
Yes, that is correct. But the first thing is that is not RB4. So Volha, I will explain it. Okay. The resin infiltration, yes, that is for the smooth
Like,
surface caries, but
right.
but for the mesial, distal, buccal, or lingual, but for the caries that in which the enamel is sound, okay, meaning that they are in the initial stages, okay, so they are not cavitated.
Not
So
cavity.
yes, so either RA1, RA2, RA3, or even these are the definites, okay, that
Okay.
you can use the resin infiltration. So RB4, why not RB4? Because if you look at the pulp chamber, and this is not the best quality radiograph, okay, but the distance, and you have to check the frontmost part of the carious lesion that we have there, okay. Although the caries that we have on the distal and on the mesial, they are not the same when you consider the size, but on the mesial, because it is closer to the enamel, I mean the dentin that we have there is in the distal is this distance is bigger. This distance, let me show you, this distance that we have is bigger than this distance that we have, so it's easier for the mesial to get to the inner third of the dentin. That is what. And thank you so much. You can go ahead and mute yourself. I'm going to ask Prakruti, who is one of our participants right now. Hi, how are you? You have to unmute yourself. Yeah.
Hi, doctor.
How are you? Good?
Good, thank you.
Did you have good rest?
Yeah, I
Okay.
slept.
So what do you call the caries that we have on the 2-7 and the mesial and distal?
2-7 distal is definitely RC5 and
Yes, and what
mesial.
if you want to assign the name to it? Is it a, can you call it a root caries? Do you call it?
Distal, yes.
Yes,
Distal is the
distal
root
is,
caries.
yes, distal is definitely a root caries, okay? And the concept of the root caries, guys, that is something which is really, really important regarding the ACJ, is that whenever we have a bone loss and we have the CEJ exposed, what happens is that we have enamel which is really resistant to acids, okay? So enamel, for decay or for the caries to start, it needs a 4.5 acidity, so it can start the caries, okay? But as soon as we have bone loss and we have the recession of the gum accompanied with it, so at the CEJ we need only 5.5 acidity for the caries to start. So the caries start at the CEJ and it expands both buccally, both occlusally and gingivally, and toward the apically. So enamel is become undermined and it's something like a scooped one. So this is definitely a root caries, and you're right. And what about the mesial caries? Do you call the root caries as well?
No.
No, it's a mesial caries. Okay, perfect. And can you comment on the restorations? What are the restorations here?
Yeah. So PFM crowns
and
composite restorations.
Yeah, PFM crown on the 2625.
Yeah, PFM crown and the 24, 25, 26. And for 3-4 distal is composite. 3-5, I think it's implant.
Yes, it's definitely implant. Yeah.
Yeah, and 3-6 it's composite as well.
Yeah, that is correct. Okay, thank you so much. You can mute yourself.
Thank you, doctor.
And no problem. So let's move on. So this is again for the distal restoration, and here there is another question, and again I'm going to give you a poll. Okay, it's good. Okay, let me end the poll and share the result. I'm just going to wait for a minute and a half. So we have Ilaf here. I think you're from Turkey. Am I right?
Yes.
Hi, how are you?
Thank
Good.
you. I'm fine. How are you?
Thank you so much, because I read the book of Ilaf Shafak, if I'm not, if I,
Elif Shafak, yes.
yeah,
Yes, she's a famous
she's Turkey.
writer.
Yeah. So what did you choose here?
So I chose distal of 4-4
Yep.
and mesial of 4-5, but right now I'm hesitant about mesial of 4-5
Why
because
is that?
it's
So basically the size of the radiographs that you are going to get in the exam is like the size of your MasterCard, okay? The credit card that you have, okay? So they are not going to be this small, okay?
yes.
Unfortunately, on the Zoom, we have two options. This is the first one, and this is the second one, okay? So do you know for which restorations we are definitely going to restore the teeth?
So for proximal caries like this, right now I can see it better. I would go and restore both of them. Yeah, I would go with composite because it would be more. Okay.
So I'm going to ask you. I'm going to ask you some questions about regarding this radiograph. So can you tell me what are the numbers of the teeth that you are seeing here? This is numbering of the teeth. Ilaf is one of the you get 2 to 3 questions just out of numbering the teeth. You don't believe it, but you are going to get. Okay.
Yes.
So have you taken the AFK?
Yes.
Did you clear it, or you are waiting for the results?
I'm waiting for the results.
Okay, just fingers crossed, huh?
Yes.
So can you number the teeth in the lower jaw, please?
40, like half of 43, 44, 45, and 46.
So first thing first. Here we don't call them 43. I know in the business they call them 43. They call it 43 because when you say, for example, 23, 24, this is another numbering of the teeth that we have, and that's universal. And this one is another thing, that this is a 4-3, 4-4, 4-5, and is it 4-6? If you number it 4-6, you will fail it. Okay, this is not 4-6. You see that it's tilted.
Okay.
Yeah, the
so
patient
it might
lost.
be 4-7.
Yes, that is definitely 4-7, 100%.
Yeah.
The patient
Okay.
lost the tooth. So this is one of the questions that they are going to give you. Okay, so ACJ is not only based for they are not just checking how knowledgeable you are. They already checked that in AFK. Okay, they already checked how knowledgeable you are. They ask everything that they wanted to ask. Okay, here in the ACJ, they want to see that how practical you can implement that knowledge in the practice. Okay, so the thing is, for example, you just think in your office, you filled out a tooth and just wrote 4-6 for the tooth that you filled, and that is a 4-7. Okay, so patient goes and wants to, I don't know, complain and says, so you are going to check the documents and you see the 4-6, and they say there is no 4-6 here, so there is a problem here. So that is why that it's very important to very, very be careful about numbering the teeth, and you have to always start with numbering the teeth in the ACJ. Okay, so here basically and you know about the ICCMS, I'm pretty sure.
Yes.
Yes. So you know which teeth are definitely going to need restorations proximally?
4-4.
No. Based on the ICCMS.
Oh, so if it's not smooth surface caries, like if it has cavitation, we are definitely going with the restoration. So but if it's not cavitated, we have other options.
No, I mean based on the radiographic extension. So based on the radiographic extension, if you have RA1, RA2, RA3, RB4, RC5, and RC6, which one are you going to consider as the teeth that definitely has to be restored?
RA3 and above, like
RB4 and above, okay? RB4 and above, because RA3 still in the initial caries lesions, okay? RA3 is, so about the ICCMS classification, because I teach ICCMS classification for our fellows in the AFK as well. ICCMS classification, the most important part is the part that they are explaining about the radiographs and about the clinical findings, okay? And that paper is very, very big and long. It's about 80 something pages, okay? So basically, if you don't read it completely, you are going to have a lot of misunderstanding while reading that paper. And that is what's happening in many places. So the thing is, those 6 levels in radiographs, they are not each of them, they don't have a clinical view. What do I mean? I mean, RA1 is not the ICTAS 1 in the clinical view. RA2 is not the ICTAS 2. RA3 is not ICTAS 3. So RA1, as I explained, RA1 is half the enamel, RA2 whole enamel and to the end. But in the ICTAS, what they say is that ICTAS code 1 is that what we can see only when we blow air on the tooth and then the tooth become white.
Right,
2, yeah. So it's a white spot, but the white spot that we can see it only when the tooth is dry. The ICTAS 2 is that the white spot that we can see that whether the tooth is dry or wet, okay? The third one that we have, ICTAS 3, is the enamel breakdown. No, it's enamel breakdown, okay? So enamel breakdown is number 3, okay, in the ICTAS, and ICTAS 4 is the brown discoloration over the marginal ridge, okay? These two are becoming moderately extensive, caries, but on the radiograph, only the 4th one is, in the middle part of the dentin becomes the moderate extensive. And when the teeth are in these, conditions, you have to restore them. So basically, the ICCMS classification is very important, and they are going to use it in the AFK, ACJ, even in the situational judgment and in the board exam, you are going to need them a lot. So RB4 and beyond, and above, you are going to restore them. On the distal of the 4-4, it seems like RC5, and on the medial of the 4-5 is still, again, it's an RC5. Okay, both need restorations. Yeah, you are right. Thank you so much.
Thank you.
Nice to see you.
Thank you.
No problem. So let me give you another poll here. So basically, guys, this is almost the same thing. This is the thing that's happening in our ACJ classes. Finish with me. Oh. Okay. Okay, that's enough. Okay. So for this question, it's asking there are evidence of restorations with overhang on which teeth. Okay, so I'm going to ask Purvisha. Hi, how are you?
Hi, doctor.
How are you? Aren't you tired already?
No, I am not tired.
Perfect, perfect. That's the spirit. That's the spirit of the person who want to pass the ACJ, you know, very fast. So what did you choose here?
I choose the distal of 425, like option D.
Okay. Yeah, option D is the mesial of the 2-6.
Yeah, distal of the 2-5, mesial of the 2-6, and the distal of the 2-7. There is a overlap in between the 2-6 distal and 2-7 mesial, so I would not comment on that one.
Okay, so do you know what does overhang mean? Exactly, what does it mean? You know, guys,
Clinically, when you probe on the tooth surface and you roll it down on the occlusally, there is a catch over there. It's called the overhang.
Yes. You know, guys, the thing which is really important is we all might have some kind of a definition for every situation based on the things that we have been taught or based on our knowledge and everything. But one of the most important things about this exam is to know exactly what is exactly the vocabulary of the NDEB regarding each option that they are providing us. So when we want to evaluate a restoration, there are some options. Okay, one of them is overhang. Okay, so overhang is, what does it mean? It means that we have a tooth here, okay, for example, like this, and there is a restoration here. Okay, so this restoration, okay, something like this. Okay, at the margin of the restoration, when we bring our probe up, okay, from the gingival part, when we bring it up on the surface of the tooth, if at the margin of the restoration it catches and it comes out, it means that there is an overhang. Okay, meaning that, what does it mean? Okay, so meaning that there might be restoration like this. For example, this is a tooth and you have a restoration that comes here and then it's become like this, like something stupid as this one. Okay, when you bring it up, you feel nothing, then you feel something. This is not an overhang. Okay, agreed? Okay, so based on this definition, for example, I can give you millions of definitions, but the thing which is only and only matter in the overhang is only just the interface. So let's dive in. For the 2-7, look at the distal part. Okay, this is the best. It is the best margin and the contour that you can get from the amalgam. Okay, distal of the 2-7 good, mesial good, distal of the 2-6 good, mesial of the 2-6 on the other hand, what we can call it overhang. We bring the probe up and it catches in the amalgam. Now about the crowns, okay, the definition that NDEB use for these conditions is not overhang, it's open margin. Okay, this is open margin, and you can see the margin of the restoration. This restoration is either not seated completely, or I don't think it's a recurrent caries here. I think it's not seated completely, maybe, I don't know. But this is not overhang because it's a gap. It's a gap there. It's open margin. It is not called overhang. If the crown was coming down here and it was like this, okay, first, again, this could be open margin. If you didn't have the open margin, you could select overhang for the crown as well. Okay, so based on what I told you, now Purvisha, what is your options for this radiograph for overhang?
D. Only
it's
D.
Only and only D. This one.
Yeah.
Okay, So this is how we address the, the problems that we have. We assign a definition to each condition, and based on that, we evaluate the radiographs. And this is exactly what they are doing, the NDB. Okay, this is exactly what you're. Thank you.
One question, doctor.
Yeah, go ahead.
In the 2.5, we said that there is an open margin. If crown is set fully and there is an overextension of the margin, then we can choose the over control. Yeah, overhang.
So for the overhang, for the crowns, okay, if you have that condition, for example, let me draw it. You have this condition. This is the root, okay, and for example, this was the crown, for example, just hypothetically, something like this, as ugly as this one. This is still an open margin, but if you didn't have the open margin in the options, you could choose overhang here as well. Yes, that is correct. Okay. This is how we address the situations, because again, there are some explanations, just specified for some situations. So, but again, that overhang for that condition is correct, but the open margin is a better way to explain it. And they are not going to give, and if they give both of them, I would choose only the best option, and that is open margin here. Okay.
Thank you, doctor.
No problem. You can mute yourself. And there is another question here. Let me give you, oh, this is a good one. Okay. For these questions with, explanation, you have to read it very, very carefully, okay? And exactly understand the situation of the patient. Okay, the time is up. Who want to volunteer for this one? It's a little bit difficult. So is there anyone who want to volunteer for this one? If not, I'm going to choose someone. I'm going to choose Rudra if nobody's volunteer. So no volunteers? Okay. So Rudra, what do you think? Hi.
Hi.
Morning, I was ignoring you. I don't know why. Sorry. So what did you choose here? Yep.
So I selected, I think it's partial, we would do partial pulpotomy because it was reversible pulpitis.
So can you break down the question for me? First of all, you have to break down the question, okay? So it's a 26-year-old patient, okay? He's young.
Yeah.
Relatively. And very short sensitivity to cold. What does it mean?
Reversible pulpitis.
Perfect. On 215. Vitality tests are within normal range. Perfect. During caries removal, there is a 2 millimeter mechanical pulpal exposure. Okay. Yeah. So what does it mean? Mechanical pulpal exposure.
It was just like removing the caries accidentally pulp exposure.
Yes, that means it's iatrogenic. Exactly, that is correct. It means that's iatrogenic. It means that caries, you remove the caries when you have this option, when you have this definition, the mechanical pulpal exposure, you have to assume that the rubber dam was on, okay, and they removed all the caries at the very end. Accidentally, they open the pulp. This is what you have to consider it when you hear the mechanical pulpal exposure. This is the meaning. Okay, so what is the appropriate management? So you said partial pulpotomy, am I right?
Yes.
So why did you choose that?
Because patient had sensitivity, so it's reversible pulpitis. It's not a normal pulp, so we cannot select DPC. If it was a normal pulp, then we would have selected direct pulp cap.
So first of all, when we choose the indirect pulp cap?
When it's a mechanical exposure.
No, indirect means indirect.
Oh, indirect?
So, yes,
there's no pulp exposure.
So direct pulp cap, what about that one?
That is, pulp should be normal. There should not be any symptoms, and mechanical or carious exposure for permanent teeth within 2 millimeter of range.
Less than 1 millimeter. Again, mechanical exposure. Again, mechanical. Yes, it has to be very small. Okay, they would give you. Okay, and there should be no sign, symptom, nothing. The patient must be just like this. This one you answered perfectly right. Okay, based on the pathway, the treatment for these kind of situations is partial pulpotomy, aka what is the other name for the partial pulpotomy?
CVEC pulpotomy.
That is perfect. Nice. You are going to pass the ACJ. Pretty sure. Perfect. So what do we do is just do a little bit of removal of the pulp, stop the hemorrhage, and put the MTA and put the glass ionomer over it, and then fill the tubes. Okay, that is the guideline treatment for these conditions. Okay, thank you so much. Lovely. Thank you. Thank you so much. You can mute yourself. Let's continue. Okay, so let me end the poll and share the results, and let me ask the next one. Dr. Mehdi, do you want to participate, Dr. Norouzi? I love the painting behind you.
Hello, sir.
How are you? Good?
Thank you. How are you?
Thank you so much. So Dr. Mehdi, so let me know. So you are familiar with the classification, the ICCMS classification, am I right?
Yes, sir.
Did you take the AFK and you are waiting for the results? Yeah. Okay, perfect. So from the distal surface of the 2-4, can you please start and tell me what are the categories of the caries that you see here from the distal of the 2?
on distal of 2.4, I don't see any lesions. There's some lucency, but I'm not sure about that.
Okay.
Mesial of 2.5, we have an RA1 here.
It is RA2. This is RA2.
RA2?
Yes, RA2. You know, Dr. Mehdi, the thing is,
Yeah.
RA1s are normally something like scooped out. It's like a dome shape. It's like a dome shape, you know, lesions. Okay,
So
they are not triangulars normally. Okay, normally.
yeah.
And at the start, they are like dome shape, and then they become triangular. It's not a rule, but it's a way to, you know, diagnose them. And on the distal of the 2.4, still we have the caries lesion as well. So what about the distal of the 2.5?
This is probably, well, this
It's a
looks
borderline.
like that is scooped out.
It's a borderline.
RA1, RA2.
It's a borderline. Okay.
Yeah, and I don't see any caries on 2.6.
Yes.
There's RC6 on mesial of
it's not RC6. No, for the RC6 you have to see it vividly inside the pulp. Okay.
Okay. Yeah.
Vividly you have to see it inside the pulp.
So
I would say it's
RC5 then.
So what which one needs restoration?
So based on what we said, I would say it's only mesial of 2.7.
That is correct. That is the only one that needs restoration. Okay, that definitely needs restoration. So what else do you see here? Do you see this the only thing that we can see here is a calcification and the pulp stone that we have there. Yeah, that's it. Thank you so much. Yeah, the answer is mesial of the 2.7. Yeah. Yes, that is correct. Any questions by now? Any questions, anything? Okay, let's move on. Okay, so let me, I should have removed this logo from here. Okay, no problem. So I think the caries lesion under 1.5, it is not really that difficult. I mostly want to talk about the caries on the situations on the lower teeth. Okay, so that is the one that is good. So I want to ask, I think Dr. Hamid is here. Huh? Am I right? Yeah. Hi, how are you? Good. I don't see you in the classes, doctor.
Because I have a full-time job.
Yeah,
I usually work from 4 a.m. to 1 p.m. So to protect my privacy, I prefer not to have camera on. But the rule is
that's good.
The camera should be on. So it's why I prefer to watch the pre-recorded.
No problem, no problem, no problem.
I know that I missed the session, but this is the problem.
You do your best. I know.
Yeah.
I know. So, Dr. Hamid, for the lower teeth, okay, can you give me your findings?
Lower teeth in terms of caries, you mean?
No, in terms of the restorations and evaluation of the restorations. Let me zoom them in, because the caries that we have on the upper teeth, we already worked a lot on the caries. So you have, ignore that logo and let me know what restorations you see here and what would you choose for the problem or anything about the restoration. What we can assign for those.
I try my best, but there are lots of emails and many things. But
is it better? Is it better?
Especially a little bit better on tooth 4, 5. I think there is a composite filling on.
Yes, that is perfect.
4, 5. We have root canal treatment plus some metal build. I think it's like amalgam buildup. Something. It's not, to my eyes, not a crown.
No, it's not a crown. No.
Yeah, and there is open margin on distal, and also I think open margin and under contour on distal of 4-6.
Okay.
4-7 has a restoration, composite restoration. There is void, there is under contour on mesial, and I think recurrent caries as well.
Okay.
Recurrent caries, I think it's a recurrent caries as well.
Thank you, Doctor. So let me explain a little bit. So on the 4-5, you said there is a composite restoration on occlusal, and that is perfect. That is a radiolucent composite that you can see here.
Yes.
Yeah. Let me. This is the radiolucent composite, and that is perfect. You know, and Dr. Hamid. My voice is coming back to my ears. Can you please let me mute you? Sorry, because when I'm talking, yeah, sorry. So for this one, these restorations, 100% amalgam. Okay, the thing is, for this restoration, for the amalgam and composite, we don't call them open margin. Okay, open margin is the term that we only use for the indirect restorations. Okay, for the crown. This is not a term that we use for the direct restorations. But if you look at it closely on the distal margin, the part that it ends and reaches the margin of the restoration, you can see a little bit of overhang. Do you see that? A little bit of overhang on the gingiva on the margin of the restoration. And the part that tooth reaches amalgam, you see that the band-like radiolucency, that is not caries. That is what, guys? What do you think about that radiolucency that you see under the amalgam? That is not caries. What do you think that is? Not burnout, not baseline liner. Nope, we never put liner here. Why should we place liner with a tooth which has, yes, that's a match band effect, this one. That is a match band effect. When we have a condition in which a very, very radio opaque, you know, restoration material or something, just it is being placed, it's placed just adjacent to the dentin, which is low, with a low density, and the bone is not covering it. Okay, so it's some kind of a match band effect that is happening all through that. Okay, and there is no recurrent caries, but there is overhang, irregular contour. You can see the contour as a problem here, and that is that. For the composite, as my dear Dr. Hamid said, exactly, there is recurrent caries. Okay, there is under contour, and it seems like a broken restoration, and it seems something is in here. I don't exactly know what that is, but it might be a part of composite that might be broken and just over there, but still it is considered as overhang, because you see that even you bring down your prop, your prop will catch the you know, that part. So it's both overhang and under contour, both of them, and recurrent caries as well. Okay, so this is how we evaluate the restorations. Okay, this is how should call the 4-6 mesial defective. 4-6 is defective. They are not defective or partially dislodged restoration. 4-7, you mean? 4-7, I think you meant. It is no partial. It's defective. They don't have a partially dislodged restoration. They don't have an option like that. They have a defective, but it seems like a broken restoration. You're right. Okay. So for the upper ones, now get back to the question that we had. Getting back to the question that we had, let me give you. So it's not really that difficult. I want to ask Simone if she wants to join. Hi. How are you?
Hello, doctor. Hi.
So did you also take the AFK? Waiting
Yes.
for the results. How was the AFK?
Good.
Good. Yeah, I heard that this time AFK was a little bit, you know, easier. Not easier, but I hope that
yes.
they don't be really harsh on you, because last time they were really, you know. So
we are all hopes for a good result to come.
Pardon?
We are all hopes for a good result.
Yeah, I really
all
wish,
of us.
You know, to be honest, Simone, the whole process of this equivalency process, really not easy. Okay,
Yeah.
the ones who enter it, they have to really be patient and they have to really do their best. And I do really hope you the best. So what do you think about the carries on the mesial of the 1-5?
Yeah, I can go for RB5 for it.
So we have RA1, RA2, RA3, RB4, RC5.
RC, yeah, RC5.
So guys, what do you think? Do you think it's RC5? So just to my eyes, this is RB4. Okay, to my eyes. And Simone, right now, the thing that they are doing in the last 2 cycles of the ACJ, they are not asking about what in which category exactly the carries, being placed, but they are asking whether the carries need restoration or not. So does it need a restoration?
Yes, because RB4 and beyond, it's considered moderate and
exactly, that is correct. So what do you think about the distal surface of the 1-5?
I can see reducing in enamel.
Yeah,
and just in enamel, and it's like the first half. So I can go for RA1.
So it is RA2, but that's fine. Okay, that is fine.
Yeah, so, and you not need a restoration for sure.
No, but what do you need for the treatment? You know?
For proximally, no, initially we don't do restoration.
Yes, you do.
So we go for preventive ones.
Yeah, we do resin infiltration. Okay.
Okay.
So do you know how resin infiltration works?
Yeah, it fills the pores.
That is correct. That is correct. So how does it work in the proximals? That is the $1 million question.
Oh, okay.
Because in the proximal, they are connecting one another to. So how does it work? You know?
No.
You don't know. So basically, Simone, yes, that is Sarita. Sarita, let me know exactly what you know. Hello again.
Hi, doctor.
I missed you. I didn't see you came. Okay. So how do you do that? Have you ever done that yourself?
No, doctor.
Okay, I've done like 1,000 cases of the ortho separator. To be honest, every case that was coming into my office and had a bite ring and there was a caries in between the teeth, I was placing ortho separator and I was calling them in for like 4 or 5 days to check the contact of the teeth. So that is correct. We place a separator, okay, and then we wait for like 3 to 5 days. It depends, and then after that we check it. And what do we do after that, Sarita?
So we first clean the tooth with pumice and then we apply HCl, hydrochloric. We let it evaporate. And we know water has a low vapor pressure, so that's why we combine with some alcohol, because so that azeotropic effect is there. So the white spot will disappear. If it doesn't disappear, we again repeat the whole cycle. And once the white spot disappear, we fill the resin like TAC DMA and cure it. And
nice.
Radiograph, you won't see any change from the big initially. Nice. You just have to follow up. If the lesion doesn't progress, it means it's successful. Otherwise, you just you don't see any radiographic changes.
Nice. Were you in my class of AFK as well? So okay, that makes sense.
From you.
Okay. Yeah, okay, that makes sense. Okay, yeah, that is exactly how it works. Okay, that is exactly how it works, and she explained it better than me. So yes, that is. Pardon?
You were very good, and whole of our batch is very thankful you taught us that restorative part.
No problem, no problem. And what I heard is that I heard the questions. People gave me the questions, okay, and I was so happy that almost everything that was included in the classes. There was almost nothing that was out of the. Just forget about the AFK now. I wish you just pass it. But the thing is, yeah. Go ahead.
In the exam, the questions they were incomplete. The question, you cannot choose whether it's ICCMS 4 or 3. they have given us like partial information, but they expect based upon that, there were questions which were little advanced, like whether it is active or inactive, without provided the exact information in the question.
So, you know, the problem, Sarita, with the NDEB is, to be honest, they are not professional. They are not professional, okay? When they want to give you and when they want to provide the questions, you know, or they don't act professionally, okay? You cannot evaluate the students based on, you know, based on the questions that are vague, based on the questions that are incomplete. This is exactly the case for the AFK, ACJ, and the skills and everything. For skills, they don't even give you the straightforward, you know, recipe to cook a good tooth, you know, to do a good restoration. They don't give it that. And why is that? Because if they want to fail you, they can fail you as they want. Okay. After AFK, you might have done perfect, but you don't know. Okay. Because you don't you know, even for us as instructor to teach you, you know, as you remember, for example, in AFK, I excluded lots of parts, okay? Because I knew they are, in the eyes of the NDB, they are not that important. So we have to mind read somehow, you know? We have to see what's coming out and then contact the students, and then based on that, you know, adjust the, you know, how we teach the students. But thank you so much for the feedback.
Thank you.
Thank you. I really hope that it would be a really easy and, you know, easy path for you. Okay, so let's have another question here, and let's see if we have, I think we have 2 minutes. Okay, no problem. We can go ahead and solve this one as well. And in my classes, time flies by. Yeah. So let me zoom it in a little bit for you. This is a very small radiograph. Just check it out. It is asking for defective restoration. Just on the upper, I think it's the upper jaw. Yes. Just check it. And now let me zoom it back for you to be able to choose the options. Okay. So I'm going to ask Dr. Ismail. Ismail, hi, how are you? Again, you have to unmute yourself. Not possible? Doesn't work? Okay. Okay, no problem. So I'm going to ask Volha, do you want to participate? Yeah? Okay. Hi, how are you?
Good, how are you, doctor?
Thank you so much. Am I pronouncing your name correctly?
Yeah, perfect. You're right.
So what do you, first of all, let me know what restorations do you see? And did you take the AFK as well?
Yes.
Yeah, was good?
I'm waiting for results.
Okay. Fingers crossed. Okay. So what kind of restorations do you see here? Can you let me know in the upper jaw first?
In the upper jaw, I can see those four. Sorry.
Yeah, you're right. It's a
yeah. So on the 1/4 distal surface, probably that is composite.
It's 100% composite.
Or maybe it was sandwich technique, something like this. I see the pore.
Yeah, there are 2 layers of composite. There might be there is a void in that. Okay, so what do you see on the what about the mesial of the 4/5, and what do you see on the 4/5?
That is crown.
Yes.
And there is overhand.
No. First,
open margin. You said.
No, forget about the problems. First, let me know what kind of a crown that is.
I would go with full metal crown.
It might be a full metal crown, or what else can it be?
Zirconia.
Yes, it can be a zirconia crown. Yes. And what do you see inside the canal? What is that?
Oh God, I'm sorry, I forgot the word. So a pin or
it's not a pin. It's not a pin. No, pin is the one in for the yeah, it's a post. It's a casting post. No, it's a casting post. Okay, because we have a prefab metal post, what you can see on the 4/7.
Yeah.
Okay, or we can have a prefab fiber post, or we have a
for sure that is casted post.
Yes, that's a casting post. So what restoration do we have on the 1/6?
1/6, that is crown. That is porcelain fused to metal crown.
Yes, this is a PFM or PFZ. It can be a PFM or PFZ crown. And what restoration do we have on 1/7?
I suppose that it is amalgam.
Perfect. 100% correct. So which restorations do you call defective here? Starting which surfaces? This is better, Volha, because this is how they are going to ask you. Which surfaces do you find defective here?
I would say that 1/5 both mesial and distal of 1/6.
So mesial of the 1/5 open margin, distal of the 1/5 open margin. Again, mesial of the 1/6 open margin, that is enough for the open margin. Distal of the 1/6 open margin. And for the amalgam, I totally agree. And for the composite, that void, we ignore it. Okay? That void that we have, we ignore it. Okay?
So you said that mesial of 1/6 is also
defective. Yes, also defective. Also defective. Okay. And yeah, that is that. Thank you so much. And let me pick another participant for the lower teeth, and we are done for today. Let me see, is there any participant in any let me see. Muna, do you want to answer the last one? The restorations that we have on the lower teeth, then we are good to go.
Okay, so we have in 4/4, we have composite filling distally.
Okay, we have what type of composite filling on the 4/4?
Proximal. Wood.
What about this one? Don't you see the buccal restoration as well?
Oh yeah, there's buccal.
Yes, that is the buccal restoration is very important. Yeah.
Yeah.
So there are composite on the mesial, distal, and buccal. So what about on the 4/5?
This is an amalgam restoration, MOD.
So this is a good one. Muna, based on what I told you, on which part do you see overhang? On the mesial of the 4/5 or the distal of the 4/5 or the both of them? Which one?
And
this is only and only on mesial. Only and only on mesial, okay? Based on the explanation. Only on the margin of the mesial we can have that catch, not on the distal. On the distal, we call it irregular contour, okay?
And it seems as if there is a root caries under the The distal surface?
It mostly seems like a burnout, not root caries.
Burnout?
No.
Okay.
Yeah, it doesn't seem like a root caries.
And for the 4-6 implant?
So 4-6 is implant crown. And how do you comment on that? Do you think it's over contoured?
The crown of the implant?
Yes.
Yes, is it over contoured? And for the 4-5, it's under contoured kind of. But this is normal, I think, in the implant because of the
exactly. On
emergence
the
of convergence. Yeah.
Yes, on the implants, because we are putting a big crown over the just a thing which is at the best case scenario is like 6 millimeter. It always seems like over contour. So no problem for the implant. The mesial surface of the 4-7 is also right, but the distal is open marsh. Okay. And thank you. You can mute yourself. Thank you guys for participating. Today's session is over. It was really fun and nice seeing you, and really hope you guys pass the AFK easily without any problem, and I would enjoy to see you in our class. Thank you. See you. No problem. Now you can go and really have a rest, guys, after 7 hours. Okay. Bye.